Hello, everyone. Thank you so much for joining us today. We're going to get started in about a minute and allow everyone to log on. Thank you, everyone, for joining us today. We're going to go ahead and get started, and I'll hand it over to our Executive Director, Laurent Hubert.
Welcome, everyone, and thank you for joining this webinar today for the public health community on the topic of smoking cessation. We have participants from all over the world, but we also have a large US contingency joining us today. I'm going to give before we start on this very important topic, which has often been somehow neglected within the public health community, I'm going to give you first a very quick overview of what ASH is, about the organization, for those of you who are not familiar with the organization. ASH was formed in 1967, and until 2000, its main mission was to protect non-smokers' rights. In 2000, it shifted and took a more comprehensive approach to protect everyone's rights from harmful tobacco products, and protecting everyone, non-smokers as well as people who smoke, from the harms caused by tobacco. And we expanded our work from working just in the United States to really taking a global approach. And we took a key role in supporting the development and implementation of the Global Tobacco Treaty, the WHO Framework Convention on Tobacco Control. And you hear a little bit more about this today from the other speakers. But the FCTC, the Framework Convention on Tobacco Control, is an evidence-based treaty that has been joined by 181 countries and the European Union. It is a legally binding treaty that calls on countries to implement evidence-based measures to decrease smoking prevalence. Measures such as increasing tobacco taxes on tobacco products, smoke-free policies, health warnings, plain packaging, banning tobacco ads, banning all flavorings, and also ensuring access to cessation, among other policies, other articles in the treaty. So that is this treaty has really become, to some extent, the best practice standard of what countries should do in order to protect the health of their citizens against the tobacco industry. We also worked to carve out tobacco out of trade agreements, for example, in the Trans-Pacific Partnership. We worked to integrate tobacco in the UN Development Agenda. And as you may know, there is a specific tobacco target and a treaty target on the Framework Convention on Tobacco Control in the UN Sustainable Development Goals. And we also work to integrate tobacco in the global UN human rights agenda. So, for example, like the UN Human Rights Council. And now we work to support novel end-game policies to help lower smoking prevalence rates. So, for example, currently we're engaged in a menthol case, suing the FDA for not taking action on menthol. And on the policy side, we're also particularly interested in addressing the supply side of tobacco products and rethinking cigarette sales, such as, for example, rethinking how tobacco products are sold, looking at the retail environment and policy that could help phase out the commercialization of tobacco products, while also taking into account the needs of people who smoke and are addicted to nicotine. And the COVID-19 pandemic is placing the right to health front and center in the public health debate, and encouraging countries to do all they can to protect the health of their citizens, as well as providing opportunities for jurisdictions to explore new ways and endgame policies to protect the health of their citizens. For example, I'm in Spain right now, and now in the context of COVID-19, smoking is prohibited everywhere outdoors in order to protect health. So, but all of those policies must be accompanied by adequate support and access to treatment for addicted smokers. And that is a problem we're facing today in global tobacco control. So we will hear more about this today. Quick housekeeping issue during the webinar. You can type your questions throughout the presentations, and then there will be ample time for questions and answers. But there's a Q&A section that you can see at the bottom of your screen, and feel free to type your questions and you can address them to a specific speaker if you choose to do so. So I want to welcome the first panelist. It's Dr. Martin Raw, who's the director of the International Center for Tobacco Cessation and is a visiting professor at New York University School of Global Public Health. He will open the webinar by providing the global context on cessation best practices. Dr. Raw, please go ahead.
Thank you very much, Laurent. So I'm going to briefly describe best practice in tobacco cessation, and I'm then going to make a few comments about how we're doing on that globally. So the first slide, please. Thank you very much. So the Framework Convention, Article 14, asks each country to develop comprehensive guidelines based on scientific evidence and best practice, and to promote cessation of tobacco use and tobacco dependence treatment. Next slide. These are the guidelines for the implementation of articles. So Article 14 itself, for example, is one paragraph. It's very, very short. And so guidelines have been written for all of the major articles to help countries interpret and implement the article. Next slide, please. The Article 14 guidelines encourage countries to create a sustainable infrastructure which motivates attempts to stop, integrates cessation treatment into national healthcare systems, and ensures wide access to support. Next slide, please. They offer guidance in three main sections. First, how to develop an infrastructure to support cessation. Secondly, the key components of a treatment system. And then they recommend that countries introduce cessation support in a stepwise way. Next slide, please. The stepwise approach is very important because it recognizes that countries have very different levels of resources available. Thus, it encourages countries to use existing infrastructure as much as possible. For example, primary healthcare system, TB clinics, and so on. It encourages the strengthening of national coordination, and that ideally includes identifying funding for cessation. And it encourages countries to develop an official national cessation strategy and guidelines. Next slide, please. The guidelines also urge countries to address tobacco cessation in healthcare workers, including incorporating cessation in training courses, training healthcare workers to give brief advice, and helping healthcare workers stop. Why is this last one so important? Next slide, please. It's important because so many healthcare workers still smoke. These are old data, but look at, for example, Slovakia, where in this survey, nearly 50% of GPs were tobacco users. Next slide, please. That was quite an old study, and so our group in the UK did a systematic review of studies of tobacco use by healthcare workers. Next slide, please. We found nearly 230 studies that met our criteria between 2000 and 2016, representing nearly 500,000 healthcare workers in 63 countries, although even so, we found very, very few up-to-date studies. The overall percentage of healthcare workers using tobacco in this survey was 21%, which is still a high-ish figure, but the highest numbers from doctors in upper and lower middle-income countries were 35 and 45%, so still incredibly high. Next slide, please. So, why is adult cessation so important? This World Bank slide shows estimated cumulative deaths from 1950 to 2050 on current trends. That's the blue line, the top line. So 520 million premature deaths by 1950 on current trends. The green line shows what happens if you can halve the number of young adults taking up smoking by 2020. You do get a reduction, but it's a smallish reduction. The red line is the key one. If you can halve adult consumption, then you get a huge reduction in premature deaths. Only adult cessation saves lives in the short to medium term. Next slide, please. Just a reminder then of some of the numbers we're talking about. There are 1 billion smokers in the world. It's 1.3 billion if you include smokeless tobacco. Most of them want to quit. Every day, a smoker over 35 continues smoking, they're losing 3 to 6 hours of life. So for the 500 million current adult smokers, that's 62 million days of life lost every day. And over 60% of current smokers who do not stop will die from their smoking. This is an urgent need. Next slide, please. So, how are we doing globally on providing cessation support? Our group did a survey in 2015, and we surveyed tobacco control contacts in 172 countries. We got replies from 142, which is an 83% response rate. So a very good response rate. Next slide, please. Basic infrastructure. I'd summarize these data by saying that overall, only around about half of countries have implemented some of the key measures to provide cessation support. Only 40% have treatment guidelines, and only a third even have an official national treatment strategy. The guidelines figure, by the way, is interesting because to create guidelines is the only concrete commitment of FCT Article 14 itself. And 15 years after the treaty came into force, fewer than half of countries still have treatment guidelines. I've highlighted the point at the bottom. Less than a third of countries even mandate recording tobacco use in medical notes. Next slide, please. Again, a similar summary that around about a half or worse of countries have these components of a national treatment system. Very few even have a telephone quick line, less than a quarter, or text messaging. Next slide. We asked about the availability of medications. Overall, availability is not too bad, especially in high-income countries. And there's a pretty good figure there for nicotine replacement therapy. Next slide, please. But affordability is another matter. Not too bad in high-income countries, but as you can see, much, much smaller ratings of affordability as the income level of the country goes down. I'm not going to talk in detail about cytosine in my presentation, but I'm happy to take questions later. But it's a naturally occurring substance. It comes from the laburnum plant. Which grows everywhere. It's been used in Eastern Europe for 70 years for treating smokers, and a full course costs less than $20. It's only licensed at the moment in 30 countries. Next slide, please. And then finally, we asked about specialized treatment provision, meaning, for example, smokers' clinics or stop smoking groups. Not particularly good provision and very poor indeed in low-income countries. The overall figure, by the way, was 26% of countries said they had these services nationwide, so only a quarter. Next slide, please. So, and I'm close to wrapping up now. So where are we now? My summary of this is that cessation support is way behind other measures in the convention, and that it is not a priority for many countries. There are lots of reasons for that, some of them very good reasons, including cost and perceived cost. On that point of perceived cost, that is why the Article 14 guidelines urge countries to start with broad reach, low cost infrastructure measures. It seems to me that it's also not a priority for many in the tobacco control field, including the MAID funders, and I'm not sure I understand why. I wonder if some people in the field still see smoking as a lifestyle choice rather than an addiction. Next slide. I would ask the question, is it ethical to introduce restrictive measures like banning smoking in public places, but not offer help to those who need it? I think we're failing many of those 500 million adult smokers, 7 million of whom are dying every year. I think we should be ashamed of ourselves, actually. Next slide. This is my penultimate slide, and it's an introduction really to the next presentation. We asked if smokers had, or tobacco users had, access to support in different settings. This one shows that only 50% of mental health units offered cessation support, and that does lead into the next talk on psychiatric, in a psychiatric setting. So next slide. Thank you very much indeed, Laurent. Very happy to answer questions in the Q&A or by email also. Thank you.
Thank you very much, Martin. And there is a very interesting point about the fact that as we implement more and more tobacco control policies, what obligations do we have, either as governments or even as a public health community, to ensure that those who are addicted to smoking can have access to cessation? And also even in the context of governments who do allow selling the selling and marketing of a lethal and addictive product, but at the same time refuse access to cessation for their citizens, which seems to be a violation to the right to health of their citizens. So we can discuss that as we do in the Q&A session. I want to introduce the two speakers now who will share the next presentation. Dr. Rachel Smolowitz and Michael Stavros of the Sheppard Pratt Hospital, and they will discuss their inpatient psychiatric hospital smoking cessation service, which is a good example of a comprehensive cessation program that has a good cessation result among psychiatric patients and could be really touted as a best practice example. So Dr. Smolowitz and Mr. Stavros, please go ahead.
Thank you. My name is Rachel Smolowitz, as Laurent said, and I'm here with Michael Stavros. I'm the smoking cessation coordinator for the Sheppard Pratt Smoking Cessation Program, and Michael is our smoking cessation counselor. We're going to speak today about the research related to smoking cessation and mental illness, as well as our experiences developing and implementing this program over the past 5 years. I will say we are in the United States. We're in Maryland, which is not far from Washington, D.C., and we do have a lot of resources available. And unfortunately, these resources are disproportionately not affecting people with behavioral health disorders. And so we really want to make sure that we're reducing that health disparity. Next slide, please. As I was saying, the rate in the United States of smokers has dropped drastically in the past 55 years. Currently, it is under 14% of adults smoke. This is due to the Surgeon General in 1954 saying that smoking causes cancer. And so this has been a really big public health push. This is not, unfortunately, the case for people with mental illness. And in our hospitalized population, our adults are even higher than our adults report even higher tobacco use. About 45% of all adults in our hospital report tobacco use. And in our co-occurring units where we treat people with substance use and mental illness, it's about 75%. Next slide, please. Even a few decades ago, it was common to provide people with mental illness cigarettes for good behavior. It was seen as something that was calming and motivating. And so now we're really fighting a health disparity that we grew ourselves as a system. And so we're still working on increasing the treatment. And as Dr. Rob pointed out, there is still a lot to be gained here. So we at Sheppard Pratt, we do have all of these services, and I'll speak a little bit more about how we have developed those in the next few slides. Next, please. First, I want to talk a little bit about some myths, and this is with thanks to Judith Prochaska, who developed these. I'm going to talk about some research information as well as some of our own findings to discuss how we challenge these myths. Next slide. So one myth is that people with mental illnesses need cigarettes to cope. And we see this because a lot of people still buy into the idea that using cigarettes in order to calm is helpful. And we see this also because when people are used to smoking and they don't have cigarettes, they have more anxiety and irritability. So we know this to be withdrawal, but a lot of people don't really make that connection. Next slide. We have a lot of research showing the benefits to mental health, substance use recovery for quitting smoking. There was a great meta-analysis in 2014 that found that when people quit smoking with mental illnesses, they have less depression, less anxiety, and better overall quality of life. And in a few minutes, Michael will talk a little bit more about how we communicate these findings to our patients to help them motivate. We also have some really great research that people who have substance use disorders are more likely to stay abstinent when they also quit smoking at the same time, and it's 25% more, which is really remarkable in that world of things. And finally, we find that tobacco smoking interferes with several medications that can be used to treat mental illness, including some antipsychotic medications, benzodiazepines, and even caffeine is less effective when people smoke cigarettes. Next slide. Another myth that I'm going to address is that people with mental illnesses do not want to quit. And one of the things that happens here is that people who are having a craving might say very loudly that they want a cigarette, and that might be very noticeable. And yet sometimes when people are really interested in quitting, they might not be as verbal about it or as vocal about it. Next slide. So this is actually from our work at Sheppard Pratt. We collect people's stages of change when we meet with them. And we find that a lot of people really are interested in quitting. In green, we have 44% of people who we meet with tell us that they are very interested in quitting, and then we're really working with them on how to quit. Another 23% are on the fence, and we're thinking about pros and cons about their smoking experiences. And when we add up those two categories, we're very close to the 70% of adults who want to quit in the general population. We do have 30% who are not interested in quitting at this time. And a lot of the time that has more to do with people not thinking that they can quit, or and some just don't feel ready to really think about it. Next slide. I'm going to speak a little bit about the Sheppard Pratt Smoking Cessation Program. Again, we are, next slide. The hospital where we work has been around for about 150 years and is now part of a large mental health system. It is the largest private nonprofit mental health system in the United States. And smoking was allowed and even encouraged for most of its history. Next slide. In 2005, this hospital building that you can see that's beautiful was expanded fairly drastically, and so they decided it was time to become a smoke-free campus, and this was also extended to other buildings in our system. And nicotine replacement therapy was provided, but the expectation was that all patients would restart smoking immediately upon discharge, and so cessation wasn't really addressed meaningfully. It was just kind of a band-aid that was put on while the person was in the hospital. Next slide. In 2015, we started a program with grant support from the State Department of Health to provide comprehensive smoking cessation. This really focused on helping people really think about the idea of quitting. And we sort of use the teachable moment that we have while people are in the hospital so that we can really help them consider it. And we did find it necessary to have one champion for smoking cessation to drive the program rather than trying to incorporate it into the roles of a lot of different people. Next slide. The smoking cessation program is built on an SBIRT model, which the S is for screening all adults who come into the hospital, or everyone who comes into the hospital. And then we provide a brief intervention, the BI of SBIRT, which involves counseling, and we do a brief motivational interviewing counseling session, as well as nicotine replacement therapy or one of the other medications for smoking cessation. And then referring people to treatment when they're leaving, including quit line and a prescription for the medication that they have found helpful. Next. It's certainly necessary to go beyond the treatment for the individual person in order to really have a comprehensive smoking cessation program. We train employees, and as Dr. Robb mentioned, we also provide them with smoking cessation tools and really encourage smoking cessation. People are not allowed to come into work smelling of smoke, not to mention they're not allowed to take smoke breaks. We also help to undermine some of those myths that I spoke about earlier, so that they're not undermining the work that we're doing and helping to motivate our patients to quit smoking. We have a fantastic peer mentor, a woman who has experience being in the hospital where we work, as well as quitting smoking, and she can really help instill hope in our patients who may not see it as very possible. Certainly, we continually work on continuous quality improvement in order to make sure that we are staying on top of everything that we're trying to accomplish. And we've had to make some changes to the electronic medical records so that we can make sure that it's part of the workflow for everybody and it's necessarily part of something that we do. Next slide. I'm going to pass it over to Michael Stavros, who's going to talk more about the implementation and how possible this has been to implement. Michael?
Thank you. I'm Michael, the smoking cessation counselor here at Sheppard Pratt, and I'm going to talk more specifically about how we use motivational interviewing techniques to help out patients address the common concerns they have regarding smoking. Next slide, please. Each of our patients, even those who want to quit, present unique challenges that they face that get in the way of them quitting. So our role in those situations is to address the problem together and try to collaborate with the patient to find solutions that are right for them. Next slide, please. So for example, we may have a patient that say that people tell them to smoke when they're stressed, something that the hospital used to self-suggest. And what we have in that situation is we try to have an honest and open discussion with the patient. We try to offer them some information, including the research that Dr. Smolowitz was talking about, where when people quit, they experience less anxiety. We would talk more specifically about how smoking can raise their heart rate and blood pressure, and that could be what elevates their anxiety. And we will encourage them to discuss subjectively what they feel is calming about their cigarette use. For many of them, it's not the cigarette itself that is providing the calming sensation, but could be something else around it, such as the relief from the nicotine withdrawal that they are experiencing, or just going out and taking a break and being away from whatever is stressing them out and taking the deep breaths that they are accustomed to via a cigarette. So once we talk to them about what they find calming in smoking, we can then engage them in a discussion of their healthier alternatives and try to collaborate to find something that will work well for them. Next slide, please. I want to quit, but I don't think I can. Thank you. This is something that we hear pretty often, and what we want to do in these situations is we want to first talk to the patient about any past experiences they have with quitting and provide any affirmations we can to any small successes that they may have to help build their confidence in their own ability to quit and reaffirm their reasons for wanting to quit. We feel that once someone feels like they can do something, once they have that confidence built up, and once they got the train rolling on wanting to quit, then they are more inclined to discuss how they can do that. So then we encourage them to use help, such as the More Than Quit line and nicotine replacement that Rachel talked about. And we would talk to them about their own resources, whether it be the support system or other coping skills that they can use to help stay away from smoking. Next slide, please. Why would I quit when I enjoy it so much? This is something we hear very often from patients who are in pre-contemplation. Pre-contemplation being just a patient who is not considering quitting right now. And in these circumstances, we find that it is most helpful not to argue with the patients and instead to stay non-judgmental and allow them to explore their own relationship with smoking and allow them to discuss some of the discrepancies they may have between their own smoking behavior and their values or goals. Those values or goals may not always be focused on their personal or mental health. It may be having to do with their family or their finances, but anything we can find to initiate change talk and get them to consider a life without smoking. Next slide, please. As I mentioned a bit on the previous slide, not all of our patients are motivated by their health. So we do have patients who would say, that, what's the point? And suggest that they are going to die nonetheless, so they may as well smoke. And in those situations, rather than trying to, once again, combat them, we want to express empathy, offer reflective listening to allow the patient to feel heard before we start trying to invite our own perspectives into it. And what we want to do is we want to try to instill some sense of hope and let them know that it is possible for them to be able to live a healthy and long life and not have to worry about smoking. And we also want to address the safety and make sure that the patient is getting the treatment that they need while they're in here. If they're experiencing any suicidal ideation or more severe thoughts, we want to make sure that that is addressed within their treatment and get that all recorded. Next slide, please. It's better to smoke a cigarette than to use heroin. We see this very often in our patients who have co-occurring substance use disorders. And in these instances, we want to, once again, just offer information and build their awareness, let them know about the research indicating that people who quit cigarettes are 25% more likely to stay away from other substances. And we want to also try to help encourage them to get away from their black and white thinking by having a dialogue with them and showing them that cigarettes and drugs are not the only two options they have. We want to engage them on what are some other things that they can use to help themselves cope with whatever stresses they may be experiencing, something that can both help them feel better and is better for them. Next slide, please. Of course, the issues that I just talked about are not the only things that come up in smoking cessation counseling session. There are many different factors that may influence one's motivation to change their smoking behavior, and we try to acknowledge them whenever possible and be aware that things such as the patient's race and ethnicity, their gender, their LGBTQ status, their physical health or disability, and socioeconomic status, as well as just their general family background, can all influence their own relationship to smoking, and try to be aware and respectful of those differences. Next slide, please. Now that we have counseled over 6,000 people with mental illnesses, we hope that we are beginning to make a dent in the significant health disparity. We want to thank you for your time, and we would be happy to take any questions during the Q&A, or you could reach us at our contact information here. Thank you.
Thank you very much, Rachel and Michael. And I see there's quite a few questions that we'll address them later, but I thought it was very interesting to hear, because within the public health community, very often we hear this, the statements that within the psychiatric community, actually nicotine might be helpful in some cases, or, in those, a lot of those patients, for them, access to nicotine is so critical. So yeah, I think you raised a lot of very good points, and I know there's a number of questions that we'll be able to address later on. We'll go on to our next speaker, which is Dr. Caroline Dressler, a medical doctor who is a surgical oncologist, who will present a practical advocacy campaign to encourage a large medical network, in this case, the International Association for the Study of Lung Cancer, to spread awareness and raise awareness around the need to include cessation in all cancer treatment plans, something that is not currently done, and unfortunately is a hurdle to recovery in the context of treatment. Carol, please go ahead.
Thank you very much. It's such a pleasure to be part of this really important webinar. So thank you so much. So It Is Never Too Late to Quit is a passionate plea for me, including for the patient who has been diagnosed with cancer. Next slide, please. So the first time that this literature was actually published was in 2014. So 1964 was the first Surgeon General report matching smoking with lung cancer. And then there had been a series of Surgeon General reports since then. But it wasn't until 2014 that there was a section in the oncology section that actually discussed the critical importance of quitting smoking if you have a diagnosis of cancer. So it is no longer just, does cancer come from cigarettes, which about a third of them do, but if you are continuing to smoke during your cancer therapy, you're not going to do as well. So this is a really important a landmark for this 2014 Surgeon General report. Next slide, please. And then in 2020, there was a smoking cessation Surgeon General report, and it also followed up on the importance of quitting smoking during a cancer diagnosis. But the whole thing is on smoking cessation. So if you're interested, and next slide, please. If you want to find it, I put up some of these links. And I will tell you quite honestly, I can never remember. So I just go to Google or Safari or whichever search engine you use and just put in Surgeon General report, and this site will come up. And so for this particular topic, you'd want to look at 2014 and the 2020 report. Next slide, please. And I want to read this, even though I really dislike when people read slides, but these are the conclusions from the 2014. And it's so important, which is the reason why I want to read it. So in cancer patients and cancer survivors, the evidence is sufficient to infer a causal relationship between cigarette smoking and adverse health outcomes, meaning you won't do as well if you continue to smoke. In cancer patients and survivors, the evidence is sufficient to infer a causal relationship between cigarette smoking and increased all-cause mortality and cancer-specific mortality. My goodness, really important to quit. Next slide, please. In cancer patients and cancer survivors, the evidence is sufficient to infer a causal relationship between cigarette smoking and increased risk for second primary cancer. So if by chance you are cured of that initial cancer, whether caused by tobacco or not, but you continue to smoke, you're at a significantly increased risk to get a second cancer. In cancer patients and survivors, the evidence is suggestive but not sufficient to infer a causal relationship between cigarette smoking and risk of recurrence, poorer response to therapy, and increased treatment-related toxicity. And in my personal opinion, the reason why it is only suggestive at this point is because we do so badly at capturing whether people are still smoking through their therapy and the impact of that smoking on their therapy. Next slide, please. Canada is, again, leading the world as they do in many things, but what they have done in their cancer centers is they have started to address this. So in 2013, Cancer Care Ontario, one of the provinces, implemented a smoking cessation program in their 14 regional cancer centers. Then in 2015, Canadian Partnership Against Cancer, a not-for-profit in Canada, convened all of the provinces, and they started a plan in order to look at how do we have all cancer care providers provide smoking cessation therapy. 2019, they then started to provide funding to do this. Next slide, please. So congratulations to Canada. In the United States in 2017, so 3 years after that 2014 Surgeon General report, our National Cancer Institute launched the Cancer Center Cessation Initiative, which is part of what they call the Moonshot program. And basically, this long-term initiative is for all of our comprehensive cancer centers to provide smoking cessation counseling in all of those cancer patients. So any patient coming to a cancer center would be enrolled in the cancer therapy. And one of the things that they'll do is, this was started by Roswell Park, where they demonstrated that an opt-out program, meaning you walk in the door of a cancer center, you have a cancer diagnosis, you will, and you continue to smoke, you will get smoking cessation counseling. You need to opt out of it. And they've shown that the overwhelming majority of patients do participate in the smoking cessation program. So it significantly increases the quit rate and the efficacy. Next slide, please. The NCCN Guidelines, so National Comprehensive Cancer Center Network Guidelines. And this in 2015, this group of cancer centers, not part of the NCI per se, but it's a network of all of these cancer centers, they developed the guidelines for how do you implement smoking cessation within a cancer diagnosis. Next slide, please. So how do you do it? Well, it's kind of the same as the first two speakers were talking about. You need to ask. And you're never going to know unless you ask, okay, and document it. And then you need to advise them. And for me in oncology is you need to educate the patient on how critical it is for their outcome that they quit smoking. So you want to assess it. But again, in oncology care, this is the one that perturbs me because I know how important the cessation is for their ongoing treatment. And then help them, either refer them, or if you know how to, then help them with behavioral counseling and pharmacotherapy, and arrange for that. So again, perhaps you refer them to somebody who has this as a specialty. Next slide, please. So what we did as an oncologist for the International Association for the Study of Lung Cancer and ASCO, the American Society of Clinical Oncology, we did a survey. Both of these are international organizations. And so we asked the oncologist, do you ask your patients? Well, they did pretty well. Do you ask if they will quit? Well, not so good considering the data. They advise them to quit. Well, again, if you ask me, 80% isn't so good if you're actually doing all of these other things in order to help people be cured of their cancers. And then discuss medications and actively treat is unacceptable. Way, way, way too low. This speaks to the criticality of the cancer center or clinic actually providing the cessation intervention. Next slide, please. So in summary, most lung cancers and other cancers and many other cancers, about 30%, it's estimated, a little over 30%, are linked to tobacco use. Most patients, just like we heard in behavioral health, most patients do want to quit smoking. And physicians need to know that data. So oncologists should know the criticality of continued smoking and their interventions. And that cessation does impact the outcomes, and it should be integrated into their overall care. Next slide, please. For this, I want to give major credit to one of my colleagues, Dr. Jacek Jasem, who is a medical and radiation oncologist in Poland. And he has really spearheaded this program for our International Association for the Study of Lung Cancer. And it's a declaration. So it talks about tobacco cessation after cancer diagnosis. So it is not talking about the causation. It is talking about the treatment and improving outcomes. Next slide, please. So these are some of the recommendations for implementation. And you're going to see it's a repeat of kind of what I said already. All cancer patients should be screened and advised, educated on the benefits of tobacco cessation for their diagnosis. So personalize the message. In patients who continue to smoke after it, they should have evidence-based tobacco cessation assistance. And it should be part and parcel of their treatment, not separated, but fully integrated into their cancer care. Educational programs about the management of it should be included. We've been working on this for years with our oncology colleagues in order to educate them of the terrific importance of addressing smoking during cancer therapy. So it should be reimbursable also, because doctors, healthcare providers get paid for other interventions. They absolutely should be reimbursed for their cessation treatment. And then smoking status should be a required data element. For me, it's kind of mind-boggling that it's not already, but it should be required if you're a part of a clinical trial. And clinical trials should be looking at assessing the outcomes of persistent smoking and how to best get people to quit. Next slide, please. So it matters what you do, so please do it. Work within your community, within your cancer centers to help your cancer patients to stop smoking. Make it easier for the clinicians. Many of the oncologists say it's not my job. I don't know how to do it. Well, let's help them figure out how to do it. Ask, advise, and refer. If the oncologist isn't trained to do it, okay, fine. Let's get other people that are trained. Like we just heard from Michael. He, perfect person who has the training to help people do this. And work with your coalitions to include and increase cessation within your cancer centers. Next slide, please. Let's get cigarette smoking out of cancer therapy. Thank you. Laurent?
Thank you, Carolyn. And so now we're going to have time for questions and answers, and we've had an opportunity to hear the global status of implementation of cessation programs around the world. We had a good example of a comprehensive program, and then you heard about the importance of including it in the context of cancer treatment, the importance of introducing cessation in cancer treatment as part of a comprehensive cancer treatment implementation. So if you have any questions feel free to type them in the Q&A box. We have a number of them. So the first question, a number of people have been asking about cytosine. And you mentioned it a little bit in your presentation, Martin. But there's questions about whether it's efficacy as well as its availability within the United States. Martin and Carolyn, you probably can address that question.
Thank you very much. It's not on prescription in the United States, no. It's not even in Britain. It's only available in approximately 30 countries, and most of those are in Eastern Europe. As I said, it's naturally occurring. It's been used in Europe for 70 years, so there's a huge amount of data on safety on the European Medicines Database, so we know it's safe. It's at least as effective as NRT. I'm not up to date with the latest trials, but I think it's as effective as varenicline. So it's safe and effective, and at the moment cheap. And the real challenge with it is to try and persuade governments to license it quickly as possible. I mean, there aren't really any reasons not to. One of the interesting points there is simply that if you follow traditional procedures for licensing medicines, there are huge hoops to jump through, including trials and so on, and that can cost a fortune. So it's an interesting regulatory challenge to try and persuade countries to use the safety data we already have, which is a huge quantity, and get the thing fast tracked. There are mechanisms to do that in some countries. Anything to add, Carolyn?
I was wondering, Carolyn, if you added within the FDA process, because I understand the FDA was looking at it, and I believe it's in some of the first phases of trial. Do you know where?
Yes, but that's one of the problems. Cytosine is made in 2 countries, Poland and Bulgaria. One of them, and I've forgotten which, has signed over distribution rights throughout the world to a company called Achieve.
Bulgaria.
Right, thank you. And that's the company that's doing the trials in the USA. The problem with that is that it's going to cost a lot. They had to get I forgot what it's called, but investment in the company to do the trials. And if and when they get the drug license, it will be much, much more expensive because of that. Which is very disappointing. They claim they'll have a dual pricing system and continue to offer it cheaply in some countries. We'll see. But that illustrates the problem. It doesn't need all these trials. That problem is a problem with I don't want to be unkind, but it's a problem with the FDA and the way traditional medicines authorities, including in Britain, regulate medicine.
I would second that. And just an interesting piece of not particular trivia is that cytosine is an herbal. It had been used, as Martin said, for decades. And then Pfizer learned about it and they created a new chemical entity. That's a fancy term, new chemical entity. And they called it varenicline. And they did all the studies. But because it was varenicline, it was a new chemical entity. That's why it was so very expensive. And so they marketed it only to countries who could afford their prices, which we could discuss those ethics also. So it is coming off of their royalty time period. And so I'm not sure what all the varenicline is going to do. I heard some rumor they're thinking about putting it over the counter, but cytosine, it's an herbal. And it does have tremendous safety data for decades. And it does have good efficacy data. That's in the New England Journal article. It was almost the same. So I would urge you, anybody who's interested in it, one, you can Google it because there actually is a ton of stuff on it. If you're on PubMed for the medical literature, just make sure you spell it right because it's a weird spelling. I try to type it in and it always goes as cytosine, which is a different type of chemical. So put in cytosine, Tisine. And you will see a lot of literature in that it's safe and effective. It has been in front of the FDA. The FDA has required yet again a phase 3 trial, a large randomized controlled study. So one could question, as Martin said, the regulatory need for that is what I would say. So go ahead, Martin.
Well, on treattobacco.net, I think treattobacco.org gets to the same site, but on treattobacco.net, which is on the Q&A there. There is, on the homepage, there's an essay on what is cytosine, and that does summarize what it is. I think, by the way, that Achieve Life Sciences are doing something with the molecule also to modify it in order to be able to get a patent, and therefore make more.
That's
Yeah.
interesting. So we do a more of a cheaper substance available, but to some extent there's restrictions for it to enter the market. And I'm wondering, and so there's a question that actually was addressed to our colleagues at Sheppard Pratt, and it's the context of because of the cost and that related to the cost of accessing cessation. So one of the tenants asked whether you're being reimbursed for cessation treatments at the full rate in accordance to the 2009 Tobacco Family Protection Act, and if you're not, is there an impact on the delivery of cessation services to your clients?
So we actually don't get reimbursed for our smoking cessation services. My understanding is that the way to get cessation covered is to do it through primary care, and since we're specialty psychiatric care, we're tertiary care, we don't have that available. We are grant funded at this time, grant funded through the state, and so the quality of our services, the impact of our services isn't really impacted by that. As a psychologist providing the services, and we have a licensed counselor providing the services, and coordinating all of it, then we can do pretty comprehensive services.
So you're fortunate to have then some support through grants and other. And so the topic of the cost of cessation always comes up and as an obstacle, whether it's talking to the public health community or even with governments. Very often when we talk about the implementation of tobacco control policies, they want some governments to talk about no cost interventions, and they see access to cessation as a cost intervention. So I'm wondering about what data do you have, and Martin and Carolyn, on the cost effectiveness of providing cessation versus not providing cessation? Because my sense is whether we're talking about the general population, cancer patients, or the psychiatric population, it's probably, I believe, this higher cost of not treating versus treating for smoking cessation. But do you have any data on that?
There's one interesting issue there is cost effectiveness and cost benefit. Helping people stop smoking is enormously cost effective and cost beneficial for healthcare systems. So it is an intervention that healthcare systems ought to have well integrated into them. It's much, much cheaper than waiting for somebody to get cancer and then trying to treat the cancer. If you compare cost effectiveness of smoking cessation with population cessation, that's apples and oranges. It's an inappropriate comparison for all sorts of reasons, including that people who go to help, who need help to stop smoking, in general are heavier smokers and are more addicted. There are data on cost benefit and affordability. We published a review of affordability and cost effectiveness a few years ago as part of the work done by the International Centre, and we developed an affordability calculator based on those data. And the calculator is interesting because it allows a country to input their own country data on costs to work out what interventions are most affordable. And we've actually used that in some Latin American countries, Costa Rica, for example, where it helps government officials, mid-level government officials, make more rational judgments on what they can afford. So there are tools available to help people do that.
I would add in oncology, there is something sort of related to that. I would echo what Martin just said, that if people stop smoking, some of the diagnoses that they may die of go away. For example, if people are not smoking, 85 to 90% of all lung cancer is attributed to cigarette smoking in almost every society, every country. So if people stop smoking, the care for lung cancer will go down. And in the United States at the present time, because of the newer therapies, they're getting, and in most countries, very unaffordable. So there is a benefit, even just with lung cancer, to stop smoking for their therapy. The other thing too for lung cancer treatment is we have lung cancer screening in order to find lung cancer at an earlier date, something similar to mammograms or other cancers, screening early. And so that has been paired with smoking cessation, and there are cost benefit analysis showing that there are fewer cancer diagnoses with cessation and that it is cost beneficial. So those are the ones that I don't have those numbers, but they have been done.
Thank you, both of you. Then next questions are for Rachel and Michael. And so there's two questions. The first one is, can you explain how changing the culture with the employees of not using tobacco or new training, et cetera, went, and whether there was a large turnover or resistance? So that's one question. And another one also that I would like you to address is on whether the program was an opt-out for prescription for NRTs medical, or was it an opt-in or opt-out, same as with counseling or referral? So whether the NRT was also opt-in or opt-out. Did that make sense with the two questions?
Yes. So I'll answer the second one first. The way that we're set up is actually, and I think this also answers another question about sudden stopping versus cutting down. The way that we're set up is we are an inpatient psychiatric hospital. So when somebody comes into the hospital, they're not allowed to smoke the entire time they're there. And I mentioned a teachable moment. So we have this time where people can get counseling, can get help. And interestingly, we have lots of people who find that it's a lot less hard than they expected it to be, which is a great win. We offer and recommend, not push too hard, but we do really encourage both nicotine replacement therapy or another medication and counseling. So, everybody's allowed to refuse it, and we really do encourage it. So people are allowed to opt out, but generally speaking, that is what we offer. The cutting down versus stopping suddenly, where that comes up is that we really encourage people to stay quit when you leave the hospital rather than picking up cigarettes and then slowly cutting down again, because of that research that you're describing. And yet a lot of people who are really more in a kind of pre-contemplation, not really ready to quit yet, or even a contemplation, I'm ready to quit, but not quite right now. That's where we definitely see people saying, well, yeah, but I'm going to pick up cigarettes again anyway, and then I'm going to quit after that. In terms of the staff, this is definitely something that many people are perfectly happy about and really glom onto and can really help support. And of course, we have plenty of people who are not too sure about it, who are not very comfortable with it. As a system that we actually have a decent amount of turnover anyway. So I don't know that there was a particularly marked amount of turnover due to the campus going smoke-free and staff not being allowed to smoke. We definitely talk with staff when they're coming in the hospital about the smoking cessation, the smoke-free campus policy, including the dress code policy that they can't smoke. And we offer right from the get-go smoking cessation services, both within our system and then the publicly available ones with the quit line. So we really encourage that. And then the rest of it is that both Michael and I sort of see ourselves as PR for smoking cessation, and we talk with people, we engage them. Plenty of staff people have come to me just to kind of chat about their ideas with, or how they're doing with smoking cessation themselves, and just getting to know staff and getting to develop that rapport with them, so that then they're speaking in sort of helpful ways with our patients can be really helpful as well.
Thank you so much. I think we have time for one last question. And it's on the possibly missed opportunities in addressing smoking cessation as part of HIV and TB control programs. Those infection disease programs do not incorporate cessation routinely, and smoking has an inordinate impact on both of their incident, therapeutics, and outcomes. So could any of you comment on how this could be better addressed as a collaborative activity for the major global efforts of those problems and the tobacco control community? I know, Martin, you have some thoughts on that. But others might want to comment also.
Thank you. Yes. What I'd like to see countries do, people in countries do, is read the Article 14 guidelines and implement them, because they contain a lot of detail about what you can do. For example, they say that before you do anything else, or anyway, when you start thinking about it, do a national situation analysis. And my center designed tools to help countries do that, essentially a a questionnaire which key stakeholders fill in. And we then go and visit the country and meet key stakeholders, Department of Health officials, together with people outside government. I know this is a bit of a roundabout way of asking that question, including Tom Novotny's question, but the point is, if you've got, the key leaders in the healthcare system, including government, in one room, which doesn't happen all that often, to talk about tobacco control and cessation treatment, you've then got the opportunity to talk about all of these things and the ways in which brief advice and cessation support can be integrated into various aspects of the healthcare system. So my message is, please read the guidelines and implement them.
Thank you. Any other comments from any of the other speakers? I'm conscious of time.
Just very quickly, I want to reiterate something that Rachel said and plug that into what Martin said. If you continue to smoke, that smoking impacts many drugs that you may be taking, whether it's for HIV, tuberculosis, or otherwise. So cessation for everyone, and cessation for anybody that enters a hospital for any diagnosis. Thank you.
Thank you very much. So we're just right about on the hour, so I'm conscious of time. I want to thank everyone for joining us today. There were some unanswered questions, but they will be, the panelists will be able to offer some written responses, and they will be receiving a follow-up email where those questions will be answered. I also want to really thank our colleagues from Sheppard Pratt, who reached out to us and proposed the topic to ASH. So thank you very much for doing so. They're the ones who initiated this webinar. Our next webinar is scheduled for September 22nd on using cessation and an international treaty and combining those to strengthen the health of DC residents. So this is something that could be replicated also in other parts of the United States. So thank you to all of you. Stay safe. And I hope that we will see you at the next webinar in 2 weeks. Thank you very much, and have a wonderful rest of the day.
Thank you very much.
Thank you.